Hi friends, in this series of respiratory system examination, we have discussed the symptomatology. From today onward, I will be discussing about the examination part. In this first, there will be general examination before starting respiratory system examination. I will talk in this video about general physical examination. Thereafter, we will go with the inspection, palpation, percussion, and auscultation in various series of videos. First is a disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Dear friends, whenever the patient of any respiratory disease reports to us in OPD or emergency or in the ward, this is a checklist which we should keep in mind. First is the initial observation. We should assess the patient while walking into the room, observe during history taking, note breathing difficulties while undressing and getting on the examination table. Check for breathlessness while moving in the bed. This is especially in inpatient patients, IPD patients. Look for respiratory signs like accessory muscle usage, use of sternomastoid muscle, LR nasi, pursed lip breathing, audible wheezing or stridor, hoarseness of the voice, whether he has any cough, whether he is coughing while talking, ability to produce a normal cough. Additional checkpoints will include check for on his bedside table whether there are inhalers, peak flow meters, tissues, sputum pot, oxygen mask, nebulizer, CPAP machine, physique and nutritional level. Whenever we examine the patient, he should rest comfortably on the bed or couch at 45-degree angle or supported by pillows for optimal positioning. We should always ask ourselves whether the patient has breathlessness at rest or exertion. Is coughing productive or dry? Is their wheezing, stridor audible or not? Before doing general physics examination, we should always ask him about the chief complaints, that is history taking. Ask about dyspnea, cough, hemoptysis, any past medical history of respiratory illness, smoking history, family history, and occupational exposure history. Coming to the general physical examination, just see his body build. Cachexia or weight loss could suggest chronic illnesses such as COPD or cancer. There are various respiratory diseases which are associated with emaciation. For example, respiratory disease associated with HIV, pulmonary tuberculosis, malignancy. There is a syndrome called Pickwickian syndrome. It is obesity hypoventilation syndrome. Patient has obesity, hypoxia, pulmonary hypertension. See the posture of the patient, whether he uses the accessory muscles of respiration, whether he has assumed tripod position, which can be a sign of respiratory distress. Check for mental status, whether he is confused, lethargic. Confusion and lethargy may indicate severe hypoxemia or hypercapnia. In general examination, we will check for his temperature. If there is evening temperature can show or can give us the clue of tuberculosis. High spiking fever can be seen in lung abscess, empyema, pneumonias. If temperature falls by a crisis, it is seen in pneumonias. Look for his pulse, rate is increased, tachycardia is there. Tachycardia is seen in pneumonia, febrile illnesses, hypoxia. Irregular pulse is seen in multifocal atrial tachycardias, atrial fibrillation. Bounding pulse is seen in carbon monoxide retention. Pulsus paradoxus is seen in acute exacerbation of COPD and asthma. Check for respiratory rate whether it patient is tachypneic or bradypneic. I will discuss respiratory rate in my few next few slides. Check for blood pressure. If there is wide pulse pressure, it is seen in hypercapnia. Low blood pressure can be a sign of hypoxia, acute respiratory distress syndrome. Postural hypotension is seen in Addison disease, paraneoplastic diseases. Look for JVP. If it is elevated, it is seen in carpulmonale, tricuspid regurgitation. Non-pulsatile jugular venous pressure is seen in superior vena cava obstruction. Check for oxygen by pulse oximetry. Look for the appearance. In the appearance, we will see whether the patient is cyanosed or not, whether the patient has a peripheral or central cyanosis. This may indicate hypoxemia. Look for pallor. If there is pallor, it may suggest anemia or poor perfusion. Pallor may be seen in tuberculosis, malignancy, or any other cause of massive hemoptysis. A patient may have polycythemia. It is seen in chronic respiratory diseases. We know that in COPD, patients usually have polycythemia. So if the patient with COPD has anemia, look for other causes like GI bleed, CKD, or coexistent malignancy. Clubbing is often associated with chronic hypoxia, COPD, lung cancer, skin changes. Look for any petechiae, rashes, abnormal pigmentation. Look for icterus. If the patient is on ATT, he may have drug induced hepatic injury. Atypical pneumonia like hemolytic jaundice may lead to icterus in the patient as a part of multi organ dysfunction syndrome. Rarely, some cancer which metastasizes to liver. In these cases, the patient may present with icterus. Look for peripheral edema seen in carpulmonale bronchiectasis. In bronchiectasis, it is because of hypoproteinemia due to loss of protein in the sputum and nephrotic syndrome secondary to amyloidosis. 100 ml of sputum can cause 3 to 4 gram of protein loss. So, protein loss is also seen in bronchiectasis. Hypercapnia induced dilatation of the precapillary sphincter, reduced renal blood flow with relatively preserved glomerular filtration rate, and elevated level of renin, aldosterone, arginine, vasopressin, and atrial peptide. Look for lymphadenopathy. Look for the peripheral signs in the hands like clubbing, I have already discussed. The respiratory cause of clubbing are carcinoma of the bronchus, pulmonary fibrosis, bronchiectasis, lung abscess, pleural empyema. Pallor in the hands may indicate TB, malignancy, or any other cause of massive hemoptysis. Warmed, well perfused palms may show carbon dioxide retention. Cyanosis may indicate ventilation perfusion mismatch and impaired alveolar arterial diffusion. Asthma, COPD, carpulmonale, respiratory failure of any cause like pneumonia, tension pneumothorax, massive pleural effusion, acute pulmonary edema, all these can lead to cyanosis. Flap may indicate carbon dioxide retention or hypercapnia, means in patients with COPD, such patients are often drowsy with warm hands and bounding pulse. A fine tremor may indicate the use of inhaled beta agonists such as salbutamol. Tobacco staining is very common in heavy smokers. In the neck, we will see raised JVP. It may be a sign of carpulmonale right heart failure because of chronic pulmonary hypertension and severe lung disease, commonly the COPD. Raised jugular venous pressure may indicate signs of carpulmonale right heart failure caused by the chronic pulmonary hypertension in severe lung disease, commonly the COPD. Sorry, this is repeated. Pitting edema of the ankle and sacrum can be present as a peripheral sign because of failure. However, the engorged neck vein due to superior vena cava obstruction, usually because of malignancy in the upper mediastinal, they may not show uh, raised JVP. The Superior vena cava obstruction may be associated with facial swelling and plethora and collateral circulation or collateral venous circulation across the anterior chest wall. So, in the eyes, we will look for conjunctival pallor, Horner syndrome, that is a Pancoast tumor, which may be pressing the sympathetic chain or sympathetic ganglion. In the mouth, look for dryness, ulcer, cyanosis, oral candidiasis, especially in patients with who are immunocompromised or on steroid long-term steroid use. So cavity examination will include halitosis, which is very common in suppurative lung disease, tobacco staining of the teeth, poor oral hygiene, oral markers of the malignancy like leukoplakia, erythroplakia, submucous fibrosis, cyanosis or polycythemia, oral candidiasis due to inhaled steroids, posterior pharyngeal wall or tonsil may show infection. The lips and the tongue should be inspected for central cyanosis, which almost always indicate poor oxygenation of the blood by the lungs, whereas peripheral cyanosis alone is usually due to poor peripheral perfusion. Oral candidiasis may indicate the use of inhaled steroids or a sign of deep debilitation or underlying immune suppression in the patient. We have to check for respiratory rate and rhythm. As we know that normal respiratory rate is 14 to 16 beats per minute when the patient is relaxing. Tachypnea is fast breathing, dyspnea is feeling of breathlessness, apnea is when the patient is not able to breathe. Abnormal respiratory pattern like giant stroke breathing, that is a cycling between deep and shallow breathing, sometimes with brief pauses, often seen in severely ill patients of heart failure, narcotic poisoning, neurological disorder. Can occurs in healthy patients also during the sleep. Sleep apnea. Here we see a pause in breathing during sleep. Central apnea is complete cessation of the respiratory efforts. Obstructive sleep apnea is the blockage of the upper airway by the soft tissues. The external markers of tuberculosis are matted lymph nodes, erythema nodosum, flectanular conjunctivitis, choroid tubercles, discharging sinus, scleroderma, lupus vulgaris, beaded vas deferens, positive Montauk's test, generalized tinea versicolors, and uveitis, and external markers of malignancy, which may indicate by the presence of cachexia, grade 4 clubbing, hard lymph nodes, acanthosis nigricans, Horner syndrome, superior vena cava obstruction, features like non-pulsatile dilated JVP, facial flushing, edema, conjunctival suffusion, papilledema, and dilated veins on the anterior chest wall. Few features of carpulmonales are because of right ventricular dilatation. Patient will have parasternal heave, epigastric pulsation. Because of right ventricular failure, patient will have raised JVP, pedal edema, tender hepatomegaly, ascites, sustained abdomino-jugular reflex, which can be a first sign of right ventricular enlargement. So the right-sided failure, patient will present with fatigue, peripheral venous pressure, ascites, enlarged liver and spleen. There may be secondary to chronic pulmonary problems, distended jugular veins, anorexia, complaints of GI distress. Patient may have history of weight gain, dependent edema. In the examination of the respiratory system, we will examine for the upper respiratory tract. Upper respiratory tract is demarcated as by the cricoid cartilage, and below that is and internally externally by the cricoid cartilage, internally by the glottis. Significant findings in the upper respiratory tract may include nasal turbinate hypertrophy or polyp causing the airway obstruction. There may be sinus tenderness suggestive of sinusitis. Cartagena syndrome is recurrent sinusitis with ciliary dyskinesia. Patient may have bronchiectasis, situs inversus, male infertility. Wagner's granulomatosis is necrotizing granuloma. Samter's stride is aspirin sensitivity, bronchial asthma, ethmoidal polyps. Young syndrome is sinopulmonary disease, azoospermia. Church-Strauss syndrome include asthma, allergic rhinitis, eosinophilia, vasculitis, granuloma. These are the few terms which I have wanted to mention. Though we don't have to see these things in patient, but we must know that if there is history of asthma and patient's blood is showing eosinophilia and patient have feature of vasculitis, we may think of Church syndrome. In Let's discuss about little bit about surface marking. As we know that the bifurcation of trachea corresponds to anterior chest wall with sternal angle, the transverse bony ridge at the junction of the body of the sternum and the manubrium sterni, and posteriorly it corresponds to disc between the fourth and fifth thoracic vertebra. The ribs are mostly counted downward from the second costal cartilage, which articulates with the sternum at the extremity of the sternal angle. As we know that right lung has three lobes: right upper lobe, right middle lobe, right lower lobe. Left lung has two lobes: left upper lobe and left lower lobe. The lung boundaries on the right side, the right lung upper border of the lower lobe, it corresponds from the line from the T2 spine from the back to the sixth rib in the in line with the nipple. Upper and middle lobe boundary are suggested by the horizontal line from the fourth intercostal cartilage to the major intercostal muscles. Left lung upper lobe apex only and the lower lobe majority of the lung. We should always think that lobes are in the form of wedges, not the cubes. If we see from the front, uh, on the right side, we usually see middle and the upper lobes on the front side, and the lower lobes on the back side. If we are auscultating the back, we will be auscultating the lower lobes from the back and middle and the upper lobes from the front. And in case of left side, the upper lobe is from the front and the lower lobe is from the back. This is a diagrammatic picture which depicts the anterior aspect of the right and left lung, posterior aspect of the right and left lung, and its various lobes, which I think we are familiar in our first year of MBBS. This is the anterior aspect of the right lung, and the anterior aspect of the lungs, both right and left, and posterior aspect. So, if a line from the second thoracic spine to sixth rib line in line with nipple, it corresponds to the upper border of the lower lobe, that is the oblique or major interlobar fissure. We should know the surface anatomy while we examining the patients. On the right side, a horizontal line from the sternum at the level of the fourth costal cartilage drawn to meet the line of the major interlobar fissure. It marks the boundary between the upper and the middle lobes, that is the horizontal or the minor interlobar fissure. The greater part of each lung, as seen from the behind, is composed of lower lobes. Only the apex belongs to the upper lobe. The middle and the upper lobes in the right side and the upper lobes on the left occupy most of the area in the front. This is mostly easily visualized if the lobes are thought as a two wedges fitting together, not as a two cubes filled one on the top of other. The stethoscope is so much part of image of a doctor that it is very easy for the student to forget that listening is only the part of examination of the chest. Obtaining the maximum possible information from your examination requires you to look, then to feel, and then to listen. Here is the demarcation of the lower lobes. The lower lobes of the either lungs can be demarcated from the other lobes by drawing a curvilinear line, that is major interlobar fissure or oblique fissure, joining the three boining points. First is the starting from the T2 T3 spinous process, a curvilinear line along the medial border of the scapula, crossing the fifth rib in the mid axillary line and reaching the sixth rib in the mid clavicular line. The part of the lung below the line is lower lobe. Let's discuss marking the right middle lobe. Drawing a straight line, that is minor interlobar fissure or horizontal fissure, from the fourth rib at the right sternal border towards the mid axillary line, cutting the major interlobar fissure at the fifth rib. The triangular area represents a right mid lobe. Whenever we are doing front examination, predominantly we look for upper and the middle lobe, and it is done by exam. It is patient examined in the upright sitting position with hands by side. In the back examination, we predominantly look for the lower lobes pathology and examine with the patient in supine, sitting upright with hands placed on the opposite shoulders and neck flexed. All three in the axillary examination, we see or we can assess all the three lobes. And here we examine the patient in the sitting position with the hands raised above the shoulder and placed on the occiput. Let's have a few words about the uh, borders of the lungs, that is left levels of the lower border lungs. In lungs, in the midclavicular, the lower level of the lung in the midclavicular line is the sixth rib. In the mid axillary line, it is the eighth rib, and in the scapular area, it is the tenth rib. You just remember sixth, eighth, and tenth for the lungs, and for pleura, the lower level of the lower border is eighth rib, mid axillary line is tenth rib, and scapular area it is twelfth rib, 8th, 10th, and 12th. For lungs, it is 6th, 8th, and 10th from mid clavicular, mid axillary, and scapular. For the pleural, it is 8th, 10th, and 12th rib. Maya Angelou has said, "They may forget your name, but they will never forget how you made them feel." With this, I conclude my today's video on general examination. In my next videos of respiratory system examination, I will talk about inspection, palpation, and percussion and auscultation step by step. Thank you. Keep learning.